So today, good evening, everyone. Today's lecture is on approach to shoulder X-rays. So basically, I will be focusing on the way we are supposed to approach the shoulder X-rays so that we are able to identify the pathology as well. Basically, we have standard radiographs for shoulder. The AP view is standard in all the departments. The second view depends from department to department. Uh, there are two options. One of them is apical oblique projection, which is also called modified trauma axial projection. Uh, this one is a better view compared to the second one, which I'll talk just in a moment. The reason being it allows gentle positioning of the patient. It provides excellent demonstration of the dislocations and shows the fracture details extremely well. So that's why this apical oblique projection or the modified trauma axial projection is better. The second best would be the scapula Y view, Y lateral view. And this is like as long as the patient's arm is not moved, the patient is comfortable. And this Y view is a little easier to interpret if you are considering the dislocations, because you can just say whether it is anterior or posterior, depending on its relation of the humeral head in relation to scapula. But this view shows the fractures very poorly, firstly, and this view needs to be technically very precise. Otherwise, there could be some uh, misjudgments. So I'll start with the basic anatomy. We all know in the shoulder, we have the clavicle. This is the acromioclavicular joint. This is the scapula. And scapula has two processes. The coracoid process is anterior, and the posterior process is the acromion process, which articulates with the clavicle. Then we have the glenohumeral joint, the main shoulder joint. Okay, and this is the greater tuberosity. Okay, this is the blade of scapula. This is the shaft of humerus. Now, this distance is important. This is the coracoid process, and this is the clavicle. So this is coracoclavicular distance, and I'll talk about it in subsequent slides. So if we start with the views, the most common view that we go for is the shoulder X-ray AP view. And the AP view is basically done in all the X-rays. It is common. The thing that I want to highlight in the AP view is that the shape of the humeral head, it looks like a walking stick. Okay, there's this illustration just to get home this point, and this has its own importance. So just remember this image, that on AP view, it looks like a walking stick. Okay. So this is the AP view. Basically, there's a bulge medially. Okay. It looks like a walking stick. This is the glenohumeral joint. This is the acromion process. This is the acromioclavicular joint. And this is the clavicle. And this is the end-on projection of the coracoid process. These are the ribs. And this is the greater tuberosity. Okay. Then the second view that we'll talk about is the shoulder X-ray apical oblique view or the modified trauma axial projection. So the way it is done is that the X-ray beam is angulated at 45 degrees. And this is the kind of view that we get. So the good part is that it gives a very exquisite detail of the glenoid cavity as well as the humeral head. So any chip fractures in this region are picked very well. The acromion lies on the top, and this is the coracoid process. I'll show you the image. This is how it looks like. This is the acromion on top. Okay. This is the humeral head. This is the glenoid cavity. Okay. Then the other view, I mean, we can use either of these two views. Either we can use the apical oblique view or the lateral scapular Y view. So the scapular Y view is done in this way, and basically in an oblique position. And the kind of X-ray that we get is this. Basically, we have the Y shape is for the scapula. This is the body of scapula. This is the coracoid process of scapula anteriorly, and the posteriorly the limb is formed by the spine of scapula and the acromion process. Okay, so this forms the Y. And on top of it, we have the overlapping of the humeral head. So basically, the anterior would be if the humeral head shifts anterior towards the coracoid process, because coracoid process is anterior. And if it shifts posterior relative to the scapula, then it becomes a posterior dislocation. So this is a normal scapular Y view. There is a lot of bones which are overlapping in this case. So this is the coracoid process. This is the spine of scapula. This is the acromion process. This is the clavicle. This is the scapula basically, and this is the proximal humerus, which is overlapping over this. So just to get the things clear, these I've annotated these. Okay. Now, how are we supposed to analyze the shoulder X-ray AP view? So there are 5 questions we should ask in these cases. First is the humeral head lying directly below the coracoid process? Okay. So normally what you'll see is on a normal view, the humerus, this is the coracoid process. The humerus aligns beautifully with the glenoid cavity. Okay. So our first question is, if it is lying directly below the coracoid process, then that signifies there is anterior dislocation. Okay. Does the humeral head have a walking stick shape, and does its articular surface parallel the glenoid margin? Like I showed you in the first image, in the AP view, it has a walking stick shape, and its articular surface of the humerus should parallel the glenoid margin. That is normal. The third question is the acromioclavicular joint normal? So how do we ascertain whether the acromioclavicular joint is normal? We see the inferior cortices of the clavicle and acromion, and they should be in a single line. There should not be any malalignment there. Then the fourth question that we have to ask is the coracoclavicular distance more than 1.3 centimeters? So I showed you in that illustration the coracoclavicular distance. If it is more than 1.3 centimeters, that means there is a uh, injury of the or the rupture of the coracoclavicular ligaments. So that's why the distance has increased. Then after these first 4 questions, then you should look for the fractures of the head, neck of humerus, the glenoid margin, the clavicle, the body or the neck of scapula, or a rib fracture. Okay. So this is a normal X-ray. We use all these things on this. So we first ask the question whether the humeral head is lying directly below the coracoid process. The answer in this case is no. But if it is lying directly below the coracoid process, then it would be an anterior dislocation. Is the articular surface of humerus and the articular surface of glenoid cavity, are they parallel to each other? Yes, they are parallel to each other and they are aligned. Okay. Then are the inferior cortices of acromion process as well as the clavicle aligned? Yes, they are aligned. So there is no acromioclavicular joint dislocation or subluxation in this case. Then this is the clavicle and this is the coracoid process. So this is the distance of acromion and the coracoid process, coracoid process and the clavicle. So this distance we can measure, it should be less than 1.3 centimeters. Okay. Then we should look for if there is any fracture of the head of the humerus, neck of the humerus, any break in the scapula, okay, any rib fracture, and all those things we should look for. Okay, so if the humeral head is lying directly below the coracoid, I've already told you it is anterior dislocation. Does the humeral head have a walking stick shape, or does its articular surface parallel the glenoid margin? So if it does not have a walking stick shape, that means it looks like it is like there is bulge on both sides or something which we call light bulb sign. So then we should use a second view to confirm the whether there is any posterior dislocation. Just not seeing the walking stick shape is not sufficient to call it a posterior dislocation. The reason being because technically if the shoulder X-ray AP view is not done in external rotation, then and then artifactually also we can have that light bulb kind of an appearance. So a second view, whether it is a axial oblique view or a scapular Y view, that should be used to see the relation of the humeral head in relation to the scapula. Again, the acromioclavicular joint, whether it is normal. So if the inferior cortices are not aligning, that means there is a subluxation or dislocation at acromioclavicular joint. And the coracoclavicular distance, if it is more than 1.3 centimeter, that means there is stretching or rupture of coracoclavicular ligaments. I'll discuss these again. Then in the second view, say if we are using the apical oblique view, which is actually a very, very good view, then in that view, the way the analysis should be done is, do the articular surfaces of humerus and glenoid lie immediately adjacent to each other? What we do in this case is we draw, I'll show you the image. I'll just read it up and then I'll show you the image. Does the center of the triangle base line up with the center of glenoid articular surface? Okay. Then we are supposed to look at, because this view shows the glenoid margin and the humeral head very beautifully. So we are supposed to look at the fractures. Because with dislocations, the fractures of humerus as well as glenoid margin are very common. Okay, so they need to be carefully looked for. Okay, so basically, this question is basically to rule out a possibility of glenohumeral joint dislocation or subluxation. So what happens is,